Honorable guests, facilitators, and all participants. Today, our topic of discussion is healthcare associated infections. Healthcare associated infections represents the major burden associated with neonatal care at hospital, thus having immense effect on the life and duration of hospital stay in newborns. Therefore, early and prompt management is need of our. The aim of the workshop is to share robust knowledge and experience of our valuable speakers for prevention of health-associated infections. I am privileged to welcome our chief guest, a renowned personality of country, Dr. Naeem Zafar. Thank you, sir, for being with us. He is founder of First Child Protection Unit in South Asia, president and honorary CEO of Pehchan, member board of director ISPACAN, International Society for Prevention of Child Abuse and Neglect. We are highly indebted for his 25 years of contribution in providing us a gateway for reduction of distressing predicament of child abuse in our country. I am also highly thankful to Professor Sajjad Maqbool in joining us. I would like to introduce our facilitator of scientific session, Professor Sajjad Rahman. He is well-known chief pioneer in field of neonatology, currently working as consultant neonatologist and as clinical director of NICU in Maternity and Children Hospital, Burade, Al Qasim, Saudi Arabia. His services are enormous and not only limited to our motherland, but also to UK, Gulf, and Canada. He has extensive experience in research, teaching, and training clinicians, nurses, and residents. I'm humbled to introduce Dr. Anjum Hashmi. Thank you, sir. He is coding specialist, certified coding specialist in USA, currently serving in Saudi Arabia as infection prevention and control specialist at Gurayat General Hospital. He is focal person and coordinator for multiple programs that includes healthcare associated infections, multi-drug resistance organisms, outbreaks in nursery, Clostridium difficile surveillance. I would also like to introduce organizer of of the workshop, Dr. Sikandar Hayat. He is well-known, recognized personality of Children's Hospital, serving as associate professor in neonatology. He is well-known for his versatile knowledge regarding patient management and organizing such fruitful academic activities up to its perfection. I also would like to invite and thanks to Dr. Nadia Majid. She is infectious disease consultant at Children's Hospital, Lahore. Her contribution in infection control measures are beyond words. I also thank to our facilitators, staff Yurusha, and technical staff Asif. Now, I would like to invite Dr. Sikandar Hayat to enlighten us with his knowledge regarding prevention of HIAs. Sir, Sajid Mukusa, please come on the stage. Sir, Dr. Naeem Zafar, sir, you are chief guest. You have to come be on stage with us.
Bismillahirrahmanirrahim. Thank you very much, Dr. Shumaila. First of all, I would like to thank our very respected teacher of teachers, Professor Sajjad Maqbool Sahab, to come in the workshop and to encourage us regarding this very fruitful, inshallah, activity. Next, I would like to thank Professor Mubin Rathore Sahab, who has come all the way from the USA to encourage these academic activity at the new Colloquium 2022. And I will extend my special thank to Dr. Naeem Zafar Sahab, who is the chief guest of this session. So, and he's here with us for next 2 hours, and he will observe. And I will especially mention that whenever he's supervising something, He has very positive feedback at the end of this any activity. Sir, thank you very much. So I have nothing to disclose. I will just briefly discuss about the healthcare associated infection. What is the problem? How significant is the problem? How does it happen? And what should be done? So what is the problem? Healthcare associated infection is an infection occurring in a patient during the process of care in the hospital or any healthcare facility which was not present at the time of admission. And usually it manifests after the third calendar day of the admission to the hospital. They represent the most frequent adverse event associated with patient care. And it is increasingly seen as a global public health threat due to increased morbidity and mortality, increased length of hospital stay, and increased overall costs. Healthcare associated infection has become a nightmare in NICUs for healthcare professionals because they are dealing with extreme age like preemies, use of central line catheters, multiple gadgets, especially use of ventilators, overcrowding, especially in our setup, where in a bed you can see we are dealing more than 4 or 5 babies. Use of multiple antibiotic, broad spectrum antibiotics, and obviously increase need for prolonged hospital stay. Especially in LMICs, the situation is more compounded due to lack of effective infection prevention and control programs, lack of antibiotic policies, poor laboratory support, suboptimal adherence to safe practices, and limited compulsion to report a healthcare associated infection. Now, how significant is the problem? 1 in every 10 patients is affected by healthcare associated infections worldwide. And in acute care hospitals, out of every 100 patients, 7 in developed countries, while 15 in developing countries will acquire at least 1 healthcare associated infection. And up to 30% of patients in intensive care are affected by at least 1 healthcare associated infection. And in developing countries, the frequency is 2 to 3 times higher. Neonatal infections at hospital are 3 to 20 times more common in developing countries, and in some settings, more than half the admitted patients acquire a healthcare associated infection with a reported fatality rates between 15 to 52%. And it is 100 times more common than early onset bacterial infections. If you talk about the data from Pakistan, a multi-center point prevalence survey of healthcare associated infection by Zikriya Salim and his colleagues have shown that if you can see, the neonates are among the age group which is most significantly affected with a rate of 23.8% of healthcare associated infection. If you talk about the areas, the neonatal intensive care is the most prevalent area with an incidence of healthcare associated infection up to 66.7%. And if we talk about financial impact, central line associated infection cost about $46 per case. And ventilator-associated pneumonia can cost up to $21,000 per case. And if we prevent 70% of these infections, The data shows in US, it is estimated to save 25 to 31.5 billion dollars per year. If we talk about the type of infections and pathogens in NICU, you can see the bloodstream infections, especially the central line associated bloodstream infections, followed by GI, urinary tract infection, and CNS infections are more common type of infections. And similarly, in the same study, if you can see that the bloodstream infections are more common among the neonates, along with the lower respiratory tract infections. And in NICU, similarly, the bloodstream infections are more common. Now, type of microorganism. If you look at this study, the coagulase negative staph is more common, especially if you talk about in 2017. But the prevalence of these microorganisms vary according to time frame. Like you can see here, the coagulase negative staph was more common in 2014, but it dips, its prevalence, its incidence drops during 2015 and 16, but again in 2017, it is the more prevalent microorganism, followed by Staph aureus, Klebsiella, and Acinetobacter species. This is the data of our unit, and that shows, if we talk about the gram-negative microorganism, the Klebsiella is the most common microorganism, and in gram-positive, coagulase negative staph was the most common microorganism in our unit, in Children's Hospital, Lahore. Now, how does it happen? It happens due to chain of infection. Starting from the microorganism, which are present at various sources of our hospital, starting from the floors of hospital or healthcare facility to the hands of healthcare providers. And they spread through coughing, sneezing, or diarrhea, transmit via 5 major routes of transmission: contact transmission, droplet transmission, airborne or vector-borne transmission. And then they infect the vulnerable population like our newborns. Now, question is how to prevent it. For prevention, first we have to develop an attitude to create an environment of zero tolerance to healthcare associated infection. Then we have to break the chain of infection. And lastly, the continuous surveillance of these infections and their reporting. And if we are talking about the prevention of these infections, then the first most important step is the hand washing. The transmission of infections through contaminated healthcare providers' hands is the most common pattern in most settings. And the failure to perform appropriate hand hygiene is considered to be the leading cause of these infections and spread of multi-drug resistant microorganisms, and has been recognized as a significant contributor to the outbreaks. Hand washing with soap and water is the preferred means when visibly dirty or soiled with blood or other body fluids. After using the toilet, and if exposure to potential spore forming pathogen is strongly suspected. while in all other clinical situations, alcohol-based hand rub is sufficient. And these are the 5 WHO moments of hand hygiene: before touching the baby, before an aseptic procedure, after any body fluid exposure risk, after touching the baby, and after touching the surroundings of the baby. And obviously, please avoid long and artificial nails, bracelets, wristwatches, and importantly, our mobile phones. For barrier precautions, gloves are indicated when there is a heavy microbial load, infants with respiratory viral infection, and before an invasive procedure. And if we talk about the disposable or surgical gown, a single gown shall be used for one baby. And gown shall be worn if a newborn is to be handled outside the incubator, and they are recommended for contact with infant with certain infection. And provision of scrub suit for personnel who spend most of the day in NICU is mandatory. Nutrition. And if we talk about the infant's nutrition, the neonatal nutrition, importantly, please encourage maternal's own milk. Human milk is the most preferred mean if we have to prevent the infections. Because, and if we talk about expression of breast milk, it may be necessary in preemies and sick newborns. So breast milk should be collected and stored aseptically. Hands should be washed and milk should be expressed into sterile containers. If you use the pump components in contact with milk, should be washed and sterilized. Use sterile water for making the formula if there is non-availability of human milk in any case. We should encourage the early start of enteral feeding and aseptic handling of hyperalimentation after their preparation. Cochrane database and meta-analysis have shown that the kangaroo mother care is associated with statistically significant reduction in healthcare associated infections. So please encourage kangaroo mother care in your units. If we talk about peripheral venous access, the hand hygiene comes first. Then please clean the area where you have to insert the needle aseptically. Then use the non-touch technique to insert the IV needles. And obviously, their adequate and proper disposal at the end. For preparation of IV fluids, after hand hygiene, please collect your materials in a separate and clean tray. That there should be a dedicated and clean area for making of these IV fluids. When you are using these IV fluids, please clean their hubs with proper disinfectant. And after that, please use sterile, disposable IV sets. For medication to be used in your units and wards and NICUs, obviously you are using vials. Please encourage the use of single dose ampules rather than multi-dose vials. Obviously, hand hygiene is must before each use of a multi-dose vial. And when aspirating the medication, the top of the vial should be wiped once with alcohol swab. And always pierce the septum with a sterile needle. Central line associated bloodstream infection has been discussed in a separate workshop last day. I will just briefly touch the neonatal clepsy is defined as the occurrence of lab confirmed bloodstream infection occurring more than 72 hours after birth that was associated with a central line. If we talk about the insertion site, please do hand hygiene, clean the insertion site with the proper antiseptic, use maximum barrier precaution and sterile dressing. While operating the hubs, scrub the hubs with appropriate antiseptic during the operation and change dressing timely and aseptically. And then the preparation of these infusates, prepare the drugs and IV fluid with strict aseptic measures and replace the infusion sets when the time is over. And for hematogenous spread, please treat the primary infection promptly. And please conduct daily assessment during their rounds for the necessity of these central lines and remove promptly if they are no longer required. Ventilator-associated infection will be discussed by Professor Sajjad Rahman very shortly. Antibiotic stewardship. We should not be partners in antibiotic resistance. By prescribing multiple and broad spectrum antibiotics, so use right antibiotic for the right patient at right dose and for the right duration. And it will be also discussed by WHO antibiotic stewardship representative in the second scientific session today. For single room isolation, the purpose is to prevent the spread of communicable diseases. And these are recommended when newborn with documented or suspected infection with communicable or epidemiologically important pathogen. Infection with airborne transmission like varicella, measles, tuberculosis, and possible influenza. Infants of mothers with perinatal varicella shall also be isolated in a single room. Equipment handling will be discussed, Dr. Anjum Hashmi. I will just briefly discuss the equipment should be clean and disinfectant between the patients. Equipment in direct contact with mucous membranes of neonate should be high level disinfected or sterilized. Equipment assigned to a single patient like resuscitation bags, respiratory mask should be replaced and sterilized. Examination equipments like stats and ophthalmoscopes should be decontaminated with alcohol between the patients. And sterile water should be used in nebulizers and humidifiers. For incubators, the inside and outside the incubators should be cleaned daily. And incubators should be disinfected between each baby. Disinfect after every 7 days of hospitalization, while for babies less than 1 kg after every 5 days. And after use, all removable parts must be washed and thoroughly cleaned. And aerate the incubator before reuse. The NICU should be kept clean and dust-free. Floors and other horizontal surfaces should be cleaned daily with water and detergent. Wiping should be used as a cleaning method. Blood spills should be removed immediately. Walls, curtains, blinds should be cleaned often. And responsibility should be assigned for housekeeping. During the construction or renovation, neonates and equipment should be moved to a separate area to avoid especially the fungi, because the fungus spore are retained in their dust. Sorry. I want to discuss this because please do avoid overcrowding wherever and whenever is possible. We are dealing this situation in our hospital and in most of the hospitals of Pakistan. And it is possible at government level and up to some extent at our level, between our network, we should develop a proper referral policy. For visitation, allow parents to visit the infant while minimizing the risk of transmission of infection. The number of visitors at a time and duration of visits is limited. Maternal visitors should also be avoided while infants are with their mothers, and visitors are instructed in proper hand washing technique, and visiting is restricted during community outbreaks of respiratory tract infections. Sufficient staff should be available to provide the appropriate care to the patients, and employees should understand the risk of transmission of infections, and potential employees should be evaluated for immunization history, and personnel who provide direct patient care shall be immune to the communicable diseases like measles and varicella. Non-immune personnel with exposure to communicable diseases, whenever these are present, please restrict the staff. Staff restriction should be implemented when personnel with respiratory tract infections, personnel with skin lesions should not perform the direct patient care, and overworked staff may not be able to comply with hand hygiene. Please do have the policy for the working hours for the staff. Handling of neonates, especially the preterm newborns, shall be minimized, and decreasing the number of heel sticks and attempts at venipuncture should be encouraged. Please do use carefully the adhesives. Avoid drugs which are associated with increased risk of nosocomial infections like steroids and H2 receptor blockers. And all NICU staff shall be familiar and regularly trained with infection prevention and control practices. If you look at these studies, starting from 1994 to 2007, done in NICUs, they all have shown that the complying with hand hygiene and other intervention have shown significant reduction in these infections at NICUs, sometimes up to 85%. But to maintain then the regular clinical audits and surveillance should be done. And this should be done with accuracy and accountability. But implementation of these practices not only required accountability, but rewarding of our healthcare providers who are combating with these deadly infections. I will summarize my talk by WHO, just a short video clip.
Her baby died in hospital after catching a resistant bug. Her mother is recovering from an infected wound after her brother's birth. She's at risk of developing liver damage after contracting hepatitis at work. His family will go without because he can't work after surgery. 1 in 10 people pick up an infection while receiving healthcare. Yet they can often be prevented and should be prevented. We all deserve healthcare without avoidable infections. This comes from cleaning hands at the right times, preparing the skin before an operation, making sure needles and syringes are never reused, as well as dispensing antibiotics only when they're really needed. That's how they provide healthcare without avoidable infections. That's how their managers provide safer care with the right training, equipment, and programs. That's how to support healthcare without avoidable infections. People's lives depend on it.
Our NICUs treats many infections. It is how good we are to prevent them as a team that makes difference. Thank you very much. We will take questions during the hands-on session of this workshop. Thank you very much.
Thank you, sir. I am humbled to pay my gratitude to Professor Akmal Laik Saab. You have joined us and graced our workshop. Thank you, sir. Now I would request Dr. Anjum Hashmi to give us a preview regarding infection control guidelines and environmental cleaning and disinfection in NICU. Thank you, sir, and please have it.
Assalamu alaikum and good morning. Today's topic is infection control measures and cleaning and disinfections in NICU units. I will start with the small introduction of this one, what measures you need for the infection control. So I will introduce what is the infection. A patient having infection before this admission is the community acquired infections. When a patient is admitted in hospital and he get infection inside the hospital is called healthcare associated or nosocomial infections. These include 4 classification or types. Infection not present nor incubating at the time of the admission. Infection appear on the 3rd calendar day of the admission. Infection acquired in the hospital, but after discharge, it is mean you will do surgeries and patient is discharged, and within 1 month, if he develop infection, it is healthcare associated infection or surgical site infection. And for the implants and other things, it will up to the 3 months surveillance period over. All will go in the category of healthcare associated infections. And healthcare associated occupational infection. We are working in hospital, we are healthy. If we get infection from the patient, it is called occupational infection, but it all comes into the category of healthcare associated infection. The infection control is here to prevent all these 4 things. Source of infection in NICU are colonized infants, contaminated hands of the healthcare workers, patient care instrument which is not properly disinfected, contaminated supplies, like creams which we applied on the skin and the cord and other things, and contaminated and IV medications, water reservoir used for the incubators and oxygen supply, infant nutrition, when perinatal nutrition is given and it is infected, not done in a proper room, which is called TPN room, and environment also of the NICU, and visitors also the source of infections. If they are infected, it will spread infection into the NICU. We prevent infection by 2 standard precautions and transmission-based precautions. So standard precaution is group of precaution which is included hand hygiene, use of personal protective equipments, waste management, disinfection, laundry management, and environmental management. And nowadays, one more thing, cough ethic is also included into the healthcare standard precautions. Hands are the top carrier of 10 top infectious germs in in our hand. We contain germs for 10 infectious diseases. We can be infected. In USA, 20,000 cases only occur due to the poor hand hygiene and bullying. Type of hand hygiene. There is multiple type of hand hygiene. According to our use, we have to use that one. Is simple hand washing, antiseptic hand wash, and hand rub. The time limit for antiseptic hand wash is 40 to 60 seconds, and have hand rub 20 to 30 seconds. Five moments of hand hygiene. Before touching the patient, before doing any clean or aseptic task, after touching the blood and body fluid, after touching the patient surrounding, and after, when you finish, number 4 is when you finish your job with the patient. This is patient surrounding. You can put incubator there in the single room. You can, all this area is the patient surrounding. Patient zone contains germs. Even you go into the NICU room, which is single, you open the door, your hand is infected. You have to do hand hygiene after that one. This is how to do hand rub. Now I will differentiate when I will use hand rub, when I will use soap and water. When my hands are visibly clean, I will use hand rub. My hand is visibly soiled, I will use soap and water. Procedure, I will show you the procedure of this one. You have to do, I will show in the this demo also, but I will tell you from here. Time limit for this one is 20 to 30 seconds. You have to rub, take the gel, at least 2 pumps you have to take, 2 cc you want. You have to rub palm to palm, 1, 2, 3. You know, the back of the hand, 1, 2, 3. Side side, 1, 2, 3. Then palm together, finger interlace. Rubbing of the sound should be there. 1, 2, 3. Then hook. Back of the hand you have to clean. Then second side, back of the hand. Then roll of the thumb. Roll of the thumb. Tip of the finger. Tip of the finger. This is hand hygiene. It should minimum take more than 15 seconds, because alcohol cannot kill germs before 10 seconds. This is the proper technique for hand wash. Few differences there. Rest is same. You have to take the water and soap in your hand. You have to rub for 15 seconds. There is no 1, 2, 3 because you see hand contains two types of germs: resident germs and transient germs. In alcohol, I am killing the germs, but in the soap and water, I am removing germs from my hand. So I have to rub for 15 seconds. I have to remove the transitional germs on my hand. I have to rub for 15 seconds. After rubbing 15 seconds, palm to palm, you have to touch all the surfaces, not like this one. All surfaces should be touched together. Go back of the hand, palm together, finger interlace. Then I have to wash my hand. Then what I have to take tissue and dry my hand. I will close the tap of the water with the tissue paper. I will not touch my hand because this tap is already dirty. These are the PPEs used in the healthcare settings: gloves, gowns, surgical mask, respirator, N95 mask, and this pepper hood. I will give in the details during the demonstration. What should be sequence of wearing and removing the PPE? Sequence for wearing is gown first, then mask, then goggles, face shield, and gloves. And doffing, you have to remove first gloves, then goggles, then gown, then mask. What happened? I saw during the COVID era how many doctors died because of COVID. They are infected because they are making mistake while they are removing the PPE. Wearing is not issue. Removing properly, timely, and technique is the needed. Patient who has got contact precaution, yes, MRSA, we have to take contact precaution. Main component of the contact precaution is gloves and gown. You will not touch any MRSA patient or MDRO patient without wearing gloves and gown. For airborne precaution, droplet precaution, surgical mask is the main component. Rest is allowed. What you have to do normally, standard precaution, attached with this one. This is must. Surgical mask for droplet precaution is must. Rest is your issue. You need for your protection. You wear it. If you feel that it is not needed, don't wear. But surgical mask is must. For airborne, N95 respirator is there. I will tell you in the workshop different type of respirators and how we should wear and which mask is fit for me or which mask is fit for you. It is, I don't know here, they are telling they don't know about fit testing. N95 mask cannot be wear, any type mask you can wear. This is a particular mask for you. For this, check which is your mask, you have to undergo the fit testing. So that fit testing, we have to tell you, this is your model, this is your mask. At least for 2 years, you can use that mask. Either if you have dental surgery or something, you can do fit test again. Otherwise, 2 years, you can use this one. Then linen management, it should be not be autoclave, but it should be wrapped while sending to the laundry, and should be plastic coated when come back. Now I come to the water there. Water. NICU cleaning and disinfection. Cleaning, physical removal of the foreign material, that is dust, soil, organic materials such as blood, secretion, and microorganism is number 2. Cleaning generally removes rather than kills. Germs has been removed, not killed by cleaning. It is done usually with the water and the detergent and mechanical action of rubbing. Decontamination, there is removal of disease producing germs to leave a item safe to further use. This is decontamination. And disinfection, it is defined as removal of the some or all the organism which is cause infection. Perfect disinfectant should offer complete sterilization, non-hazardous, inexpensive, non-corrosive, but unfortunately we don't have such type of disinfection. And if few is there, very few, if there, it is very expensive, we don't use. For our purposes, I developed that one. Chlorex or bleach is final product for us, which is the resource limited countries. Here you see the spores until the envelope bacteria, viruses should be complete disinfection, acceptable, which control all things. This all germs should be, this is all three stages should be covered. You see this quaternary ammonium compound covering until here. Then there's alcohol until here. But this one, hydrogen peroxide, aldehydes, chlorides, and this peroxides, enzyme, this all covered total. But these products are very expensive. Our is this one, chlorine. So we hyperchlorate we will use to cover from the bacterial spore to envelope viruses. Then bleach is, God has given us bleach. It is very effective. There is no resistance to this one. Why it is not? Because it does not go into the cell, and cell can produce resistance to that one. It touches the wall and it bursts. So no chance of resistance to bacteria or anything. Same. Now, strategy and approaches of cleaning. Surface cleaning with minimal hand contact, such as floors, ceilings, those with the frequent hand touch, it's high touch surfaces. And this one, door handles, knobs, is high touch surfacing for housekeeping. So you have to clean high touch surfaces many times in a day. And for the minimal floor and the ceiling, we have to arrange our protocol according to period, weekly, monthly. You can do it for this one. And no need of fumigation for aldehydes or anything is needed for the general routine terminal cleaning is enough. With Chlorex, you can get it, this one. For dilution, for routine surface cleaning, 1% or 1000 ppm of chlorine is okay. So 10 ml in 1 liter, it is okay for routine floor cleaning on all this one. If you want to disinfect, blood stain is there, blood spill is there, you have to prepare 10%, which we done, and this is also used for instrument. 5000, 6000 ppm we can use for the instruments also for high level disinfections. So it is made by 100 ml of the bleach and 900 ml of water. In outside world, there is Chlorex is present, but concentration of that Chlorex is 5.25 to 6.25. But in, I check it here, this Robin bleach is available, it is 3.5. So how I will combine this concentration to find this level? I will double the dose of this Robin bleach in when we will use here, because for the disinfection this is needed. Oh, yeah. Now time duration. For the recommended time, bleach oxide carried out by the chlorine is rapid. 10% dilute will be generally achieved within 2 minutes. So 2-minute contact time is enough if I clean an incubator and then after that one I will disinfect with the chlorine mop or spray with the chlorine solution, air dry. It is in 2 minutes it will be air dry and it will be disinfected. And for the instruments, 10-minute contact type, we will leave for at least 10 minutes. We don't leave more than 10 minutes because decoloration of the tubings and other instrument can occur with this one. So less than 10 minutes, final contact time for this one. Now these products are all Clorox modules, but we don't have here, I think. So wipes, I will show you how this wipes. So we can use this one for our disinfection and all the things. NICU equipment disinfection protocols. Disinfection of the instrument direct contact with the skin and mucous membrane of the newborn should be sterilized or undergo decontamination with a high level of disinfection. That is 100 ml of the Clorox with 900 ml of water. Examination instrument, stethoscope, pulmonoscope, other things can be disinfected by 70% alcohol. The equipment not direct contact with the skin and mucous membrane should be cleaned by the detergent and water. So we can use here, we can better use Savlon and water. This is the time limits for they say protocol. What is the wipe the surface, observe the contact time, and dispose the glove. This one. So we will use same procedure, but upon local made wipes. This is also the 3 steps equipment disinfectant protocol. You have to wipe, clean, sanitize your hand. Exterior of the surface should be clean. Here they also say same thing, the time limit should be completed 2 minutes here. All the bacteria, this is Clorox. For the Clorox, they have told bacteria 30 seconds, virus 1 minute, then molds and fungi 5 minutes, and Clostridium difficile spores also 5 minutes. So 10 minutes you will do, it's okay for the instruments. Okay, incubator cleaning, we will go in details when we will do in hands-on. So this is the cleaning. We have to clean every 7 days. Daily, you have to clean from the top. You cannot do disinfection of the incubator daily from inside because baby is already there. So outside you can clean and rest on the 7th day, and small babies 5 days. And for this one, disinfection, you can use half the concentration of that one, for the blood and body fluid we are using. Environmental cleaning and housekeeping. Dust, you should not do dry mopping. It should always be wet mopping. And I don't know here is be done mop heads are laundered or not. Basically they say it should be laundered daily. Cabinets, all horizontal surfaces, at least once daily you have to do with the intermediate level disinfectant. Windows, shelves, non-critical surface should be scrubbed periodically, weekly or monthly. You can make it according to your protocols. This is the steps for this one. First of all, remove the dust, then wipe with this one disinfectant, and contact time absorb, and residue should be cleaned because some powder is left in the Clorox when Clorox dries. So have to wipe this one also. So you same thing I told you before, the cleaning should be done, then this disinfection of the organic matter should be by doing a brushing, because you see Clorox neutralize, if you put as organic material, it neutralizes. So you have to clean. First is cleaning, properly cleaning, then disinfection. How you should arrange? You have to make a clean team, which will include the head nurse, cleaner supervisor, and the people who's working is there to arrange protocols for this one. When we have to do this thing, when to do this item, that item, and you have to organize and educate the clean team how they should clean different items, including instruments and all other things. This is new approach is coming up, new clean care modular intervention. Here they say in the resource restricted countries, you have to use mothers with clean staffs. Because of lack of staff, cleaning is left behind to the optimum level. So mothers who are present with their babies, you should teach them how to clean. You will provide them things. But I will show next slide how to teach them. This is the form which should be present in each room, and pictures are already there. Instrument, but with instrument you want or things you want to take mothers, you put the pictures, because illiterate mothers cannot read from there. They take the picture and they will clean from this one. And morning and night shifts you have to do. This is the new program, and it is very effective. They say has produced the results. Thank you. Bob. After that. Video.
Thank you, sir, for such an enlightening talk. Now I request Professor Sajjad Rahman for his discussion on most distressing condition of our NICUs, vent-associated pneumonias. Thank you, sir, and please join us.
Assalamu alaikum. Thank you very much. Just in continuity to what Dr. Anjum Hashmi said, every one of you has been given this form, which is the Neo Clean Care Program. Kindly take it with you to your units. You can make copies of it and use it into daily practice. And similarly, the 5 moments of hand hygiene, as well as the other techniques of cleaning, they are given in 3 forms. If anybody hasn't got it, may I request the organizers to please distribute it and give it to everybody. And you can take as much copies with you as possible and put it into daily practice to enhance infection control and prevention in your NICU. Now coming back to the my own presentation about ventilator-associated pneumonia, what we call VAP. This is one of the important healthcare associated infection in the intensive care, more in pediatric and adult ICUs than in the NICU. So how do we define VAP, which is an infection because of the ventilation? And we know in the NICU, we have a lot of interventions. We breach natural barriers and enter into spaces which are supposed to be sterile. And respiratory tract is one of the areas which is normally supposed to be sterile. And every time we intubate the baby to ventilate, we breach that barrier. So longer is the intubation, longer is the ventilation, longer is the risk of getting infection in the lower respiratory tract. Similarly, we keep on doing suctions from the respiratory system because of secretions. And more we go into the respiratory system with our catheters to do suction, more is the risk of getting infection into the respiratory system. So how do we define it? So pneumonia occurring in a patient within 48 hours or more after intubation with an endotracheal tube or tracheostomy tube, and which was not present to start with, which means the patient was not admitted because of pneumonia. It was some other reason due to which we had to ventilate the patient. But 48 hours after that, we found that the patient has got pneumonia. Because we intubated, we ventilated. So by definition, that will be the ventilator-associated pneumonia. So it's one of the most common and fatal infection in intensive care units. And it increases the length of ICU stay by 28%. So the longer the infection goes, the longer will be the stay. And it costs a lot in terms of patient care and money to the health system. And VAP is used as a KPI, key performance indicator in ICU. It is one of the quality question. What is the quality of care in your NICU? That is measured by different KPIs. And one of the KPI is the incidence of VAP, incidence of ventilator-associated pneumonia. So how do you diagnose? It's very challenging, and particularly in the NICU. In the NICU, it is the preterm and extremely preterm babies who are on the ventilator. More preterm, longer is the duration of ventilation. And most of the time, these preterm babies develop changes in the lung because of the ventilation and prematurity, what we call the chronic lung disease, and what we used to call previously as bronchopulmonary dysplasia. Then it becomes very difficult on the X-ray itself to differentiate between chronic lung disease or severe chronic lung disease, BPD, and what we call the pneumonia. And again, these preterm babies are very much prone to frequent collapses in the lungs. And then it becomes difficult to differentiate that collapse between collapse and consolidation, and whether this is bronchopneumonia or just a collapse because of the prematurity. So it is a challenging issue. So more than 50% diagnosed as VAP actually do not have VAP if we go for the autopsy findings. And up to 1/3 VAP remains undiagnosed. So what is the standard? So there is no clearly accepted gold standard for VAP diagnosis in any ICU, whether that is the NICU or PICU or adult ICU. But there are certain criteria, and we divide them into radiological signs, clinical signs, and microbiological criteria. The radiological sign, which is the first one we see, there are 2 or more serial chest X-rays done, and they should show at least one of the following. Number 1, new, progressive, and persistent infiltrate. Number 2, areas of consolidation, and number 3, cavitation. Clinical signs, the patient should have fever more than 38 degrees centigrade with no other apparent cause of fever. And in newborn babies, particularly in preterm babies, we may not get fever. We may get sometimes hypothermia. On the blood examination, there should be leukocytosis or leukopenia. In adults, they consider altered mental status as well, which is not the criteria we use in the NICU. This is mainly the adult criteria, at least two of the following: new onset of purulent sputum, new onset of worsening cough, dyspnea, or tachypnea. And on examination, you may find rales, bronchial breath sounds, and worsening gas exchange or blood gases and ventilation requirements. So the patient keeps on requiring more and harder ventilation, which means the respiratory function is deteriorating. The microbiological criteria, at least one of the following: either he should have positive blood culture with no other reason, positive pleural fluid culture, positive BAL culture, bronchoalveolar lavage culture, positive gram-stained bronchoalveolar lavage with more than 5% cells, and histopathological evidence of pneumonia. Now, this is a typical X-ray of a preterm baby with chronic lung disease. And looking at this X-ray, it becomes very difficult to say whether this baby simply has got chronic lung disease and severe BPD, or is there any element of pneumonia or bronchopneumonia. So it becomes really very challenging in the NICU. So what to do with the VAP? So prevention is the key. Like any other healthcare associated infections, we have to prevent occurrence of VAP. So how do you prevent it? We come with a set of evidence-based interventions and we put them together and we call it bundle. So we have a VAP bundle. Just like prevention of CLABSI, central line associated bloodstream infection, we have a CLABSI bundle. Similarly, for urinary tract infection, we have a COTI bundle. So for VAP, we have a VAP bundle, which is a set of interventions which can help us reduce the incidence of VAP. So what does that include? First and the most important thing is the training of healthcare professionals, which we are doing today. And this is not going to be limited up to here. You have to go back to your NICU and train every single member of the NICU and sensitize them. They should know that their day-to-day bedside practice can change the incidence of all infections. And as other colleagues have mentioned, starting from the very good hand washing, the washing of equipments and practices and everything. So everybody must be trained and they must be sensitive. And they should know that they are the key people who can prevent all these healthcare associated infections by their day-to-day simple practice, which should become a second nature of everybody. Everybody coming to the NICU, whether he is from the healthcare workers or even the parents and other visitors, they must know how important it is to start with the hand washing when they enter the NICU. Second thing, the VAP bundle, adherence to hand hygiene, as I said, and correct use of sterile gloves prior to the management of ventilation equipment and supplies. So the problem is coming from the equipment, through the equipment and to the personnel who are handling the respiratory equipment. So cleaning of the ventilators and starting from the process of intubation itself, how vigilant we have got to be to make it sure that when we intubate the baby, starting from that point, we have to be sure that we do not introduce any infection in the respiratory tract. So sterile management of airway. When you are intubating, you should have total barrier prevention, which means you should have sterile gloves, gown, mask, and cap. When you are using a suction system, if you have the facility, it is better to use what we call closed suction system. This is a system in which we do not take the catheter out of the connecting tube. It goes back into its own fold, and then you go into the endotracheal tube, do suction, it comes back. So it does not get exposed to the outside. It's a bit expensive, but if it is possible, we should use that. And whenever we are doing suction, we should use separate suction catheters for the oral suction and a separate one for the endotracheal tube suction. Fourth important thing is avoid reintubations if possible. So we'll extubate the baby only when we are confident that we don't need to reintubate. Every time we reintubate, the risk of sepsis increases. So first thing is every day you take a ward round, you should decide whether really we need to keep this baby on the ventilator or can we manage him on the non-invasive ventilation. If it is possible to manage on the non-invasive ventilation, better to extubate and put on the non-invasive ventilation, which will decrease the risk of infection. One of our consultant, when I was doing my fellowship in Canada, he used to say, less plastic in the body means baby is getting better. So every piece of plastic you take out, whether that is the endotracheal tube or NG tube or urinary catheter or IV line or central line, more plastic is out means more baby has the chance to get better. So take the plastic out as much as you can and as much as is possible. So daily evaluate, and the similar we say for the central line as well, whether it is PICC line or surgical central line. Every day we used to have what we used to call the CLEPC maintenance bundle, line maintenance bundle. Do we need the line or not? It was an item in the daily ward round. Similarly, in the daily ward round, you need to know whether do we need to keep the endotracheal tube in or should we take it out? And of course, if it is possible to provide 1-to-1 or maximum 1-to-2 nursing care for babies who are ventilated, so that there is no cross-infection between the babies. So less is the number of nurses and more babies they handle, more are the chances of cross-infection. Then oral care is very important because oral cavity is one of the places from where we can get a lot of secretions. We can trickle down into the respiratory system, and particularly if the babies aspirate as well. So regular cleaning of gums, tongue, lips with a sterile swab or gauze coated in distilled water. And the nurses should be expert in this. This is a routine daily care done every 6 to 8 hours by the nurses. Positioning of the baby is very important. Regular alternate postural changes so that the secretions do not accumulate in one or the other place. So babies don't have to be kept all the time in supine position. You can ventilate them better in the prone position as well. You can ventilate them on the side, one side or the other side. So frequent change of position helps in drainage of the secretion. And if the babies have gastroesophageal reflux, then we usually have head up by 15 to 30% to decrease the incidence of reflux and aspiration. Feeding, a bolus feeding is more helpful. 2-hourly feeding or 3-hourly feeding based on the gestational age and weight of the baby, instead of giving a continuous feeding per hour. Care of the ventilator circuit is extremely important, and we are going to talk about it during the hands-on training. And this should be done with 2% chlorhexidine in 70% alcohol to be used, as Dr. Anjum has already mentioned. ETT connections and the self-inflating bags, which we usually keep on the bedside and we use them for the resuscitation, they should also be cleaned. Change circuit only when it is malfunctioning. So this is one of the recent studies published in 2021, which they have shown that what they have done in the pre-bundle era and the post-bundle era in 2018, you can see that the incidence of the VAP has tremendously gone down with the implementation of the bundle. Again, the same thing which Dr. Anjum Hashmi had mentioned, and which we always say that NICU is a teamwork. NICU is not a one-man show. You can bring the most famous professor of neonatology in the world, he cannot do anything. Nurses are as important as is the professor of neonatology. And your respiratory therapist, your cleaning workers, your the people who clean the floors and equipments and everything, they're all very important. Every single person in the NICU is equally important, and we all have got to work together. This is a spirit. This is a mindset. And when you enter into the mindset, enter with the same mindset. That it's not a one-man show. I cannot make any difference. We have to make a difference. So create an environment where everybody thinks that he is important and equally important, and everybody must be a part of the change. You cannot bring any change, you cannot make any survival, you cannot reduce morbidities without every member of the team being equally involved in the care of the newborn baby. I think that's the end. Thank you very much. I think we'd like all of you to come. Dr. Anjum is going to lead the hands-on training, and we'll try to finish it in 45 minutes. Try to learn the hand washing techniques, equipment washing techniques, and the management of the ventilation. Thank you very much. Yes, okay.
हेलो ये नीचे कहाँ है PP पहनने से हैंड हाइजीन पहले अच्छा ओके जी वी विल स्टार्ट विद द हैंड हाइजीन प्रोसीजर procedure of hand hygiene. So what I had already told, when my hand is visibly clean, I will use alcohol gel. I will take, open kare yaar isko. Ho gaya? I will take 2 pumps, at least 2 pumps mean 2 cc will be there. I have to, kya hand wash? Soap hai? No. नहीं ये सब वही है अल्कोहल जेल है बे यार क्या सुबह मुझे बताया था ये अल्कोहल जेल है ओके जी अल्कोहल जेल और अल्कोहल स्प्रे I have to take 2 pumps. So at least 2 cc with my hand. Then I have to start with the, please raise your hand with me. Palm to palm, 1, 2, 3. And back of the hand, 1, 2, 3. Second side, 1, 2, 3. Palm together, finger interlace. Rubbing, 1, 2, 3. Sound of the palm should be there because I have to rub. Then hook, back of the hands. Then second side, back of the hands. Roll of the thumb. I have to clean this area. I have to clean this area, both thumbs, tip of the finger, tip of the finger. This is hand hygiene. Let it dry, air dry. Then you, every time you wear PP, lazim you have to do hand hygiene, and don't wear gloves until it is not dry. When dry, otherwise it will dermatitis will happen to you. Okay, this is one for the alcohol gel. Soap and water. Take soap. Same procedure. I will throw this one. Do कोई जरूरत नहीं करने की ठीक है okay I will take wet my hand I will take sabun here soap I will rub wet hand for 15 seconds continuous 15 seconds please do it with me because procedure is necessary WHO is impressing upon these steps if you do like this one it means you are missing things so you do it for 15 seconds you have to do then back of the hand palm together finger interlace back of the fingers roll of the thumb dry tip of the fingers then wash I will take tissue बस tissue नहीं है कोई बात नहीं okay I will take tissue I will wipe I will tap close the water tap with the tissue this is my hand time limit for this one is 40 to 60 seconds okay okay then we will go to this one to the PPE, I will go reverse because N95 is, I will start with the N95, then normal gloves gone and I will wear. So different types of N95 available. N95 for Chinese model, this is all in this USA. Okay, this is N95. How to wear this one, which is my mask. I have checked myself with the fit testing protocol. This mask model number 3M8060 is my mask. So I have to only use this mask. If it is not there, I cannot protect myself. So I have to wear this one. How to wear this one? Put on your face, upper, then lower. Then I have to do seal check. If I am not doing seal check, it is useless. Seal checks mean it is totally sealed or not sealed. So I have to put, first of all, I will make this bridge to my nose. I will put my hand here and blow. Any air coming outside from here or here, I move and adjust it another. Every time seal check you have to do. Otherwise, it is useless wearing the N95 and I cannot wear for 4 minutes if it is properly sealed. Otherwise, I can wear. I will leak here, it will go, I will move around, no problem. But lazim, you have to do seal check. The step is moving and nothing is leaking. Okay, this is seal check test for this one. Whenever I do my work, then I have to remove first. Don't touch front of the mask. This one. Throw in the bin or now because of money, we are in Saudi, we are reusing for 5 times. So we will put this one into the brown envelope, put up my name and I will hang it there. Second time, third time, fourth time you have to use. This is the Kimberley class, another type. It is same procedure. Make it your nose. बीच में डाइस बढ़ा दे एक मिनट and I have to check any false seals here. If no faults, I will make it my nose, then I have to blow. It is working. If I break this seal, it will not work. So seal check is lazim. 100% you have to, otherwise you are an exposure to the germs. Okay, how to do this one? Okay. This is all another type, no problem. You can do. Now I will, take this. This is the front side of the mask. This is the inside. The dark side should be outside. If the color difference is not there, this waves going down is the outer side. You should not wear reverse. But in COVID, we said, because every people wearing how it is wearing, we don't take serious now what to do. So I have to wear this mask. I have to make this my nose. I have to stretch it full. So there should be no gap in my cheek and this one, and air should not go from here. So I am protected now. Okay. Like this one, same. We will start now PP hole again. This one, this one. So donning, I told you how to don and duff. First of all, I have to wear to do hand hygiene. Already I have done hand hygiene. Don't wear any PPE without hand hygiene. बांध दो टाइट करके जरा। पूरे यहाँ तक कवर। Then from behind, I have to cover my torso. I will not wear like this one. I have to cover my torso total, and then I have to tie this one behind. I will not tie this one here. So behind. Okay. Okay. Then second, I have to take my mask and rewear it. And finally gloves. ये खोल लिया आपने? रहने यार, क्यों ज़ाया कर रही हो? I have to cover this white inside my glove. This I am wearing, it is not, it is wrong. So you have to cover this one like this one, okay? चलने दो, कोई बात नहीं. अच्छा. Now we will start our things. Then I will duffing I will show later. Now I will teach you how to make this antiseptic or Clorox swabs, which we don't have in the canisters because it is very expensive. This water is 500 ml. I will put 100 ml in. इसमें डालो 100 ml दो. डाल दे इसमें. मास्क पहन लो तुम, इसमें स्मेल आएगी. ठीक है जी, ये आपका सॉल्यूशन तैयार हो गया क्लोरेक्स का. और ये इसकी वैलिडिटी यूं समझे 5 to 6 hours. Within this time chlorine will evaporate and finish things. You have to make fresh one. So I will put this by this one, and this I can use after clean in instrument. I clean all this one, final disinfection with this one. Okay sir, this is procedure for the, okay. Now we will come to this stage, small instruments, how to do this one. Like this Clorox प्ला दे दे मुझे, उसमें साबुन, ये this one. नहीं नहीं इसमें नापना नहीं है, डाल दो साबुन तो उसके डाल दो थोड़ा यार लड़की, कैमरे के सामने हट जाओ भाई. अच्छा खोल के दें आप मुझे. अब स्कोप डिसइंफेक्ट में आपको बता रहा हूँ मैडम, ये लो इधर से, ये खोलिए. ठीक है, सोप एंड वाटर के साबुन में मैंने डाल दिया पानी में. मैनुअल क्लीनिंग भी करेंगी. उसके बाद मैनुअल क्लीनिंग के बाद इसको ब्रश से साफ कर सकते हैं. कोई चीज अगर हो इसमें लगी हुई है, जैसे ये लगी हुई है, रब कर सकते हैं. मैंने इनसे छोटा वाला ब्रश मंगाया था, निपल ब्रश, उन्होंने मुझे ला के ये दे दिया है. ठीक. Then same I will dip in this one for 10 minutes. Second, for this one I will not dip this one, I will use alcohol swabs for disinfection of this one. खोल के दो यार इसको. Because battery is there, you cannot put it into the water. Same procedure for this one, and stethoscopes you can use split swab, 70% alcohol, proper alcohol. Okay. डस्टबिन भी नहीं है. अच्छा जी, ये समझे 10 minutes हो गए. We remove this one. We will let it in the towel to air dry. After 10 minutes, you can pack it and use this both. Now, अच्छा उसमें साबुन डालो, साबुन, ओ ये सेवलॉन डाल दो. बस सही है. अच्छा, this is clean water, this is Savlon water, and this is Chlorox water. Basically, for the tubing and all this respiratory small instrument, soap and water is enough. But you need sterilized water or distilled water. For the far-flung area where it is not, you are using tap water. That's why I add one bucket for the Chlorox for the disinfection. Okay, और खोलो. हाँ सब इसमें डालो, वॉश करो, आपका काम है ये तो. हो गया, डालो उसमें. This इसमें now this is 5 liter to produce the 500 ppm, 5000 ppm. We have to put 200 milli here. 2 liter water is there, 1 liter. So 200 is there. It is 5 minutes because rubber side is to 5 to 10 minutes. We will need take out. आपको finish इसको पैक कर दो. बस ये clean dry हो गया. जगह हटा दो. बस आप बस ये समझो पैकिंग का थैली यही है ना, पैक कर दो, डालिए. We don't have pouch, so we are putting into the plastic this ones to secure this both. So like this one packing, we secure this one here. Now we will start with this one. This one, you see 10 minutes already passed. Let it this bamboo bag to dry, air dry. Okay. And now I will make the spray also. Spray like same disinfection. The swab you will make 500 ppm spray, antiseptic spray. So 500 ml water is there. I will put 100 ml of the Robin bleach. It will become 5000 ppm, 5000 to 6000 ppm. उसमें एक ही बहुत है, डालो, गिरे नहीं बाहर. Okay, now our ambu bag is dried. I will put into sterile paper and label it and send to department. This is okay. This is also used spray if you anticipate tables and all the areas which you want to spray. Even incubator you can spray with this one. If you don't want to use this one, you can use this one. Now we will come to this one, disposable units disinfection. This is the more expensive things. How to disinfect this one? Cheapest method. Otherwise, you can. This is disposable, but it should be used until it is non-dirty. So one patient changes, you can use this for the second one after disinfection. Okay, I will show you how to disinfect this one. This is CPAP. आप आ जाओ इधर देखो, ये सब चीजें लग हो गई सही. सब निकालो. इसमें तो एयर जाता है ना, इसको जरूरत नहीं है ना। हाँ बस बस ये, और तो कुछ नहीं होता जिसमें। सो वी विल, सामने हट जाए, we will put this one in soap and water, let it sunk there, so water should go inside, and we will do like this one. So water should cleaning, all the things should be cleaned inside. Leave it for 20 minutes, 20-30 minutes for this soap and water. Okay, so let's 30 minutes finished. I have to drain all this soap from this one. You have to milk this one slowly, don't put pressure because it's disposable one. Okay, now because I don't have distilled water or any water, it is tap water, so I'm using it to remove the soap and water from here. Let water go inside, we will clean from inside. And finally, after removing the soap, let it open out, need to technical hour. Okay, clear. Now I am putting this one where I put already water and Clorox. So for disinfection, maximum 10 minutes, 5 to 10 minutes. Take more than that one, otherwise discoloration will happen to this one. Okay, time finished. I clean this one for 10 minutes and disinfected. Now I have to dry. Let it air dry. Same procedure we will take out from this one. निकल यहाँ कल देखो क्या निकल, वो डिसमिस होगा ना, ये भी होगा, होना है ना, उसे पूछ क्लीनिंग दिस वन ना, करनी है ना, बस सही है। ओके, इसकी पाइपिंग की, क्योंकि इसमें सिर्फ एयर की सप्लाई है, यू हैव टू डिसइंफेक्ट दिस एरिया ओनली। एयर सप्लाई वहां से आ रहा है, फ्रेश एयर। नहीं सेंसर, ये तो कनेक्टर्स हैं उसका, वो बॉटल पंग इसकी है बॉटल, हाँ ये बीच में सेंसर, वो हीट मॉइस्चर सेंसर, वो फिल्टर नहीं होता, वो आपको नहीं चाहिए। हो गया जी साहब। अच्छा, छोटी पाइपिंग के लिए मैंने बोला था छोटा ब्रश जो इसमें चला जाए, तो वो ले लें आप, बस ज्यादा नहीं। हो गया जी, यहाँ पर 10 to 20 मिनट्स में यहाँ गुजर गए इसके, हमने इसको प्लेन वाटर में डाल दिया। अब आपने क्लोरेक्स पे इसको 10 मिनट्स के लिए डाल दिया, और ये इसका पोर्शन, ये वाला भी इसको आपने डिसइंफेक्टिंग के लिए डाल दिया जी। चलो जी, चलिए निकाल दीजिए बस, ये भी हो गए इसके जी, टाइम रनिंग अवे ना। चलिए वहां आ जाए, लो भाई टांग इसको। नहीं आएगा इसमें। ला यार बीच में होल्ड किया है या बीच में ऐसे डाल दो यार, इसमें कोई मसला नहीं है। हैंग कर दो सेंटर में ऐसे। नहीं लटकी रहेंगी ये, नीचे ड्रेन नहीं होंगी ना अदरवाइज। तो नीचे छोड़ दिया वो बड़ा करना आपने। ये निकालो, यहाँ से निकलता है यार, ये निकलता है यहाँ से नहीं निकलता, तो फिर लंबा होना चाहिए थोड़ा, मतलब ऐसे को इस पानी तो उनसे ड्रेन हो जाए। इसमें डाल दो ऊपर वाले में, ऐसे करके आ जाएगा डर। हाँ चलो ठीक है, आप देखो। हाँ ये तो नीचे आएगा ना, इससे लटका दो ना। ओके लगा यार, हो गया ठीक है जी। नहीं ये स्मॉल पार्ट्स को आपने टॉवल में रखना है, एयर ड्राई, क्लीन, वाइप एंड एयर ड्राई, एंड पैक करके इसको यूज कर लेना। ठीक है जी, आगे जाते हैं वेंटिलेटर के ऊपर। तो वेंटिलेटर की क्लीनिंग टॉप टू बॉटम, never go from reverse direction. Okay, then screen, don't use chemical, don't use anything, you will use alcohol, sprit, swab. Yes, we are using. Oh, for hazy. Sure. Okay. Okay, maybe. You will take this papers more.
मैं कह रहा था हैंड रब वगैरह भी ना यूज करें, क्योंकि उसमें भी अल्कोहल बेस्ड होती है।
जी जी,
ये इन चीजों के लिए, ना सेल फोन के लिए, ना आपकी स्क्रीन के लिए, और ना इसके लिए।
तो इसका जब आप whoever buying that expensive equipment, they recommend some solution, okay, and that solution should use. होता ये है कि जैसे आपका ऑफिस है, उसमें उन्होंने जो क्लीनर्स होते हैं, they use the simple thing, it destroy the skin.
yes I know.
I lost $60,000 monitors just because of this solutions. So not all the solutions, be careful. जो इसके अगर कोई मैन्युफैक्चरर हो वो यहाँ पे, तो वो आपको बताएंगे।
गाइडलाइन है उनके पास मैन्युफैक्चर। यार उस क्या था उसके अंदर, पेपर के अंदर स्क्रीन की क्लीनिंग का? सर को दिखाओ क्या लिखा है, सर को दिखाओ।
हाशमी सर, सॉरी, ये जो मल्टीपल ट्यूबिंग है
जी,
एक पेशेंट की ट्यूबिंग एक ही दफा जो है ना क्लीन करें कि मल्टीपल पेशेंट्स की ट्यूबिंग एक टब में हम जो वॉश कर सकते हैं?
नहीं नहीं ऐसा कुछ नहीं है
जी।
पेशेंट बेसिकली ट्यूबिंग, अब आप देख रहे हैं वैसे तो सिंगल यूज है, आप थ्रो करें, आप नहीं कर सकते तो यू हैव टू यूज, यू कैन यूज इट फॉर मल्टीपल पेशेंट फॉर दिस वन। ओके, दिस इज नॉट द इशू। आपको वॉश, सिंगल पेशेंट अगर आपके पास 1 महीने के लिए, यू चेक द ट्यूबिंग इज विजिबली डर्टी, you go and change, clean it and put it back.
Thank you.
This is why, because things are how to make simple and cheaper. Otherwise, okay, sir. We will come to this one.
Hashmi sir.
Ji, sir.
As I said in my last slide, that this infection control in the NICU is a team work. And team doesn't mean only the team in the NICU. There is a wider team around you in the hospital. So the hospital has to have an infection control and prevention department, which most of the hospitals probably in Pakistan don't have it. Many of the functions which Dr. Hashmi is telling is not the function of the NICU team. It is the function of the control department. They should come, their infection control practitioners should come daily to the NICU and get all these things done for you. They are supposed to be supporting you. Similarly, there is another department, what we call CSSD, Central Sterile Supply Department. So all your equipments like laryngoscopes and all these things and intubation and blah, blah, everything, it should come packed. You should send them the dirty one, they would clean it, they would sterile it, they would pack it, they would send it back to you. The only responsibility you have is that when you are intubating a baby or putting any central line or PICC line or whatever it is, or any procedure, USC, UVC, then you should get a set which is already sterile and made for you. So it is a big teamwork, not only the team in the NICU, but a system in the hospital which must support you. So when you go back, please talk to your administration. They must establish these departments, and if they have these departments, they should make it very efficient and make it helpful for the NICU.
Okay, sir. For CSSD, what I will say, I don't know here how you are managing your sterilizers. Sterilizers, we are using 3 indicators. One is biological, which we are used in weekly to check this sterilizer is working. Other is biological BVDX. You will do? One is for CSSD, 3 indicators are necessary. One is biological indicators. They are running this one for weekly one time, okay? And they put in some machine and it will say growth is coming or not coming. That the same result will come in the CSSD same time. So no weightage is sending to microbiology or other thing. This is the biological indicator. And then this is BVDX indicator. This is paper with the design. You will put it in the morning. You have to put it. Then inside the instrument tray or this papers, chemical indicators are going.
My question is that if we have a sterilizer, why don't we put laryngoscope, everything in that, and after some time it is sterile?
No, it cannot be sterile.
Why?
These things, laryngoscope, we have done in the, our hospital, this lights going out. Some time it is not working, some it is heat, they're melting the plastic over the light. Many problems happen. I have to start many things. Then
Sir, I have the same question.
don't do it.
What about these tubes and
Tubes cannot stay in only few things, which is for the incubator, for the sterilizer. Rest is disposable. Heat, you will put it, heat, it will melt. So,
देखिए यूँ है कि 2 किस्म के हॉस्पिटल्स हमारे पास हम डील करते हैं. एक का जिनका CSSD वेरी वेल एस्टैब्लिश्ड, दे विल टेल यू कि क्या चीजें आपने भेजनी है. फॉर एग्जांपल, जब आप एक सिंपल प्रोसीजर कर रहे हैं, लेट्स से आपने सर्कमसिजन किए, उसके इंस्ट्रूमेंट्स हैं, या कोई छोटा माइनर प्रोसीजर किया, उसका एक तरीका होता है. वो आप इंस्ट्रूमेंट्स उसमें डालते हैं, उसी में जो जिस रैपिंग में आता है वो वापस भेज देते हैं. तो वो जो है वो CSSD को पता होता है कितनी देर उसको स्टेरिलाइज करना है. फिर उसके ऊपर जब वो कर लेते हैं तो लेबल लगा के वापस आपको भेज देते हैं, नाउ इट इज रेडी फॉर यूज. जो आप बातें बता रहे हैं बहुत यूजफुल हैं, बिकॉज नॉर्मली ये जो ट्यूबिंग है ये तो है डिस्पोजेबल. हमारे हिसाब से it is better to use disposable rather than to go through this exercise in general.
yes.
मगर आप बिल्कुल सही कह रहे हैं कि for many of our hospitals that is not possible. Many of our patients have to pay for all of these tubings and it is not possible. Many of the patients have to stay on this for a while. तो आपको circuits जो हैं उनका खास तौर पर ख्याल रखना पड़ता है. मसला हमारे इसमें ये है कि यहाँ जो आपकी बातें सुन रहे हैं, डॉक्टर्स हैं और नर्सेज हैं. ना डॉक्टर्स ने स्टरलाइज करना है ना नर्सेज ने करना है, सुपरवाइज करेंगे. ये काम जिस तरह हमारा होता है ना कि नर्सेज को आप कहें कि इसको ज़रा इसका ये डायपर चेंज कर दें तो वो स्वीपर को बुला लेती हैं, तो स्वीपर बदलता है. यूरिन का भी वो स्वीपर ख्याल रखते हैं. तो ये जो स्टरलाइजेशन होती है ये अस्पतालों में इस तरह की जो आप कह रहे हैं सफाई आया करती है. हमारे यहाँ पर जो लोएस्ट होता है ना वो इसको दिस इज कंसिडर्ड डर्टी वर्क. नो नर्स विल डू इट, आई कैन टेल यू. एंड दिस इज द प्रैक्टिकल एस्पेक्ट. बुरा मनाने की बात नहीं है, मगर ये अब ये जो चीजें हैं उनको इन लोगों को इसलिए मालूम होना चाहिए, डॉक्टरों को, नर्सेज को, कि जब वो अगर वो करें तो सुपरवाइज करें. मैं ही समझता हूँ कि हम अगर इतना ही सीख लें कि हम रोज के रोज, मैंने थोड़ा सा कल अपनी टॉक में इशारा भी इसका किया था कि रोज के रोज जिस तरह आप जो सरफेस हम यूज कर रहे हैं, जो हम हैंडल्स यूज कर रहे हैं, जिस तरह आपने बताया डोर हैंडल्स हैं, सरफेसेस हैं, जो हम इंक्यूबेटर्स के आउटसाइड है, जो हम टेबल्स यूज करते हैं जहां हम काम करते हैं, हम हैंड हाइजीन का ख्याल रखें, हम ये सेल फोन्स का ख्याल रखें, ये अपनी बेस्ट ज्वेलरी पहन के और नर्सिंग ना करें लंबे लंबे नाखून लगा के, और नर्सेज ना आए, बालों को कवर करके रखें, डेली वहाँ पर हमारा जो नर्सरी में जो कपड़े हैं वो अलग होने चाहिए, लाइक स्क्रब्स होने चाहिए, ताकि जो इन्फेक्शन जो हमारी ज्यादा है ना वो इस तरह फैलती है। आप बताइए ना, वेंटिलेटेड तो हमारे जैसे अस्पतालों में होते हैं ना, जो जहाँ वेंटिलेटर्स होते हैं और जहाँ वो होते हैं, मगर जहाँ पर ज्यादा हैं, जहाँ पर सो कॉल्ड न्यूबॉर्न नर्सरीज हैं, या जहाँ वैसे हाई डिपेंडेंसी यूनिट हैं, मगर इक्विपमेंट वगैरह बड़ा मिनिमम सा है, वहाँ पर भी मेरा ख्याल है जो बाकी मेजर्स हैं उसमें हमें ज्यादा तवज्जो देनी चाहिए। मैं ये नहीं कह रहा आपने ऐसा नहीं कहा, मैं सिर्फ रीइटरेट कर रहा हूँ बताने के लिए उनको कि उन लोगों को मालूम होना चाहिए कि उसकी इम्पोर्टेंस बहुत है।
सही बात।
ये आपने जो बताया है ये बहुत जरूरी है, इम्पोर्टेंट है कि आप साबुन इस्तेमाल कर सकते हैं, साबुन को निकालना बहुत जरूरी है, बिकॉज ये सर्किट में अगर साबुन रह जाए, रेजिड्यू रह जाए, उसमें और प्रॉब्लम्स होते हैं। उसमें से पानी से उसको साफ करना, और फिर वो पानी साफ होना चाहिए, क्योंकि हम अपने नलकों से पानी नहीं ले सकते। जो हमारे नलकों के पानी का हाल है, अगर वो आप देखें तो वो कई मरतबा पानी नहीं होता, कुछ और होता है। तो वो भी जो पानी है वो या साफ पानी होना चाहिए, उबल के होना चाहिए। और तीसरा जो आपने ये बताया है कि उसमें आप ब्लीच डालते हैं, उसकी रेशो और प्रोपोर्शन जो है वो बतानी चाहिए। अब यहाँ पता नहीं सिकंदर है या नहीं है इस वक्त, तो मेरी मैं आई एम श्योर आप कर रहे होंगे बहुत सी बातें, मैं प्रिज्यूम करता हूँ। मेरी ये सजेशन थी कि इसकी आप एक वीडियो बना ली आपने इसकी, तो एक ऐसी वीडियो पूरी बना के जो आप जिस तरह काइंडली आपने किया है, इसकी एक वीडियो स्टेप बाय स्टेप बना के हमारी हर हॉस्पिटल में हमें ये उनको वहाँ नर्सेज को और डॉक्टर्स के अलावा जो वहाँ पर आया है उनको दिखानी चाहिए। और मेरे ख्याल में उसको हमें उर्दू में बताना चाहिए, क्योंकि बहुत से लोग जो हैं वो अंग्रेजी को इस तरह नहीं समझ सकते। आप हैरान होंगे जिन्होंने ये सफाई करनी आया वगैरह, वो तो उर्दू भी कई मरतबा नहीं समझती, तो हम उनको अंग्रेजी में कैसे समझा सकते हैं। और नर्सेज ऑफ कोर्स दोनों समझ सकती हैं, मगर एक मरतबा हर महीने उसको छोटा सा वीडियो चला दिया जाए कि ये तरीका है, ये करने का तरीका है, तो फिर वो रीइंफोर्स होता रहता है। तो इतनी जब आपने मेहनत की है तो थोड़ी सी और सही, और एक वो वीडियो बना के, और ये जिस तरह आपने ये बताया ये तो बहुत अच्छे हैं ना, मगर ये भी बनाए, क्योंकि हमारा अगर हम आप सोचें फॉर अ मिनट कि हम अगर इन्फेक्शन अपने नर्सरी से या हमारे न्यूनेट से निकाल दें तो हमारे मुल्क में तो रेवोल्यूशन आ जाएगी न्यूनेटल एरिया में। और ये बहुत सी सिंपल चीजें हैं, ना डॉक्टर हाथ धोते हैं, बल्कि मैं समझता हूँ नर्सें ज्यादा हाथ धोती हैं, डॉक्टर कोई नहीं हाथ धोता। वो बस आते हैं, जितना बड़ा डॉक्टर होगा वो ऐसे दाखिल होगा और इधर हाथ मारा, उधर हाथ मारा, फोन जेब में से निकाला, फोन पे बात की, अच्छा ये कर दो, वो कर दो। सॉरी, मगर यहाँ बहुत से बड़े बड़े डॉक्टर बैठे हुए हैं, मगर हम सारे इसी तरह करते हैं। और वो बातचीत करके और वो वहां से वो चले जाते हैं। काम तो सारा नर्सेज ने करना होता है, और नर्सेज ने क्या काम करना होता है, जो वो खुद करना चाहती हैं वो करती हैं, वरना वो आगे उसको आया या स्वीपर को कहती हैं कि वो करे। और छोटी छोटी बातें होती हैं। मैं बताऊं आपको, ये कल मैंने थोड़ा सा आप बात की भी थी, यानी इन चीजों का ख्याल रखना होता है कि हम नर्सरी बना लेते हैं, हमें ये नहीं पता कि सिंक कैसा होना चाहिए। अभी यहाँ मेरी कॉलीग कल बैठी हुई थी, पता नहीं आज है या नहीं, डॉक्टर तैयबा, उनका यूनिट बना है नया सर्विसेज हॉस्पिटल में, वो जब वो यूनिट बना है तो आप हैरान होंगे, नर्सरी में सिंक ही नहीं था, हैंड वॉशिंग के लिए सिंक नहीं था. शी रिफ्यूज टू टेक ओवर एंड देन अंटिल दे बिल्ट द सिंक्स. जो सिंक, डॉक्टर साहब करेक्ट मी इफ आई एम रॉन्ग, यू आर द एक्सपर्ट, आई एम नॉट, कि वो भी फ्लैश स्प्लैश फ्री होना चाहिए. यानी उससे छींटे, ये नहीं है कि आप हाथ धो रहे हैं तो 2 फुट तक तो उसका पानी जा रहा है. और वो एल्बो चाहिए. सर्जन्स क्यों वो यूज करते हैं? बिकॉज वो हाथ नहीं लगाते, एक मिनट तो हाथ स्टेराइल हो जाए तो वो एल्बो से करते हैं. अब एल्बो में करने में क्या कबाहत है? और अगर उसको आप इस तरह डीप वाला बना लें, वहां लगा दें, मेरा ख्याल है वो सस्ता मिलता है, जिसको सर्जिकल स्क्रब सर्जिकल वो कहते हैं. देखिए ये जो छोटी छोटी चीजें हैं, ये हमें इन्फेक्शन कंट्रोल, फिर आपके डिस्टेंस बिटवीन इनक्यूबेटर्स, वो किसी ने बात नहीं की, इन्फेक्शन उससे भी फैलती है. आपने 6 बच्चे बताए हैं, तो मैं ऐसे ही सोच रहा था, मैं खुद चिल्ड्रन के साथ एसोसिएटेड रहा हूँ, मुझे मालूम है कि मसला होता है. मगर ये भी तो हो सकता है कि और कुछ नहीं तो हम छोटी छोटी पार्टीशन उनके दरमियान बना दें कि कम से कम उनका थोड़ा सा तो कांटेक्ट उसका अवॉइड हो सके. मगर हमें बहुत सी मजबूरियां होती हैं, हमें अपने इंडिजिनस सॉल्यूशंस भी ढूंढने पड़ेंगे. और ये बहुत मुफीद है, बहुत ज़रूरी है. मगर इसको जिसको हम कहते हैं कि बहुत बड़े पैमाने पर हर छोटे बड़े अस्पताल में इसको फैलाने की ज़रूरत है. अगर आप इसको प्रोफेशनली आए में डॉक्टर साहब इनसे फ़ायदा उठाएं, उर्दू में बनाएं और स्टेप्स बताएं उनको, बना के जितने पैसे लगते हैं वो हम लगाते हैं और वो वीडियो बनाते हैं. सज्जाद साहब भी हेल्प करते हैं, जुनेद साहब भी करते हैं. उसका एक अच्छा से वीडियो बना के वो आपकी तरफ से वो हम सारे अस्पतालों में घुमा देते हैं. और वो चाहे वो बशीर आबरू साहब मेरा ख्याल है बैठे हुए पीछे, ये वो बलूचिस्तान ले जाएं, वो सिंध में ले जाएं. इतना बड़ा क्लेम होता है कि सिंध में, मैंने कल परसों किसी में टीवी स्टेशन गलती से मैंने लगा लिया, बोल तो लगाता नहीं हूँ, मगर वो लगा लिया तो वो कह रहे थे कि जी जितनी अच्छी हेल्थ केयर सिंध के रूरल एरियाज में है, वो तो इस तरह बातें कर रहे थे जैसा पूरी दुनिया में नहीं है. और हाल ये है कि वहाँ पानी है नहीं, तो भाई हेल्थ केयर तुम क्या प्रोवाइड कर रहे हो? और किसी ने मुझे बताया कि वहाँ वेंटिलेटर भी नहीं है. वो तो चलो वेंटिलेटर तो छोड़ो, मगर ये छोटी छोटी बातें जो हम ये कर सकते हैं ना, जो हम कर सकते हैं, ये हम सबको फैला दें. ये हमारी जो नियोनेटल जो फ्रेटर्निटी है हमारी, जो उनकी तरफ से ये एक गिफ्ट होना चाहिए उनके लिए कि ये आप ले जाइए, ये तरीका है, ये ग्लव्स पहनने का ये तरीका है, मास्क ऐसे पहनने हैं, हाथ ऐसे धोने हैं, इतनी देर के लिए इसको रखना है. ये जो बातें आप सब बता रहे हैं, तो ये स्टेरलाइज करना है तो इसको इतनी देर के लिए रखना है. क्लोरॉक्स की जो आप ब्लीच की जो रेशो बता रहे हैं उसको प्रैक्टिकली बताएं. और ये बताएं जो जो चीजें यहाँ मौजूद हैं हमारे पास, ये मत बताएं जो हमारे पास नहीं है, वो हम नहीं कर सकते. तो मेरा काम नहीं था एक्चुअली, नईम का काम था ये सारा. मैं चूंकि नईम मेरे साथ बैठे हुए, तो मैंने थोड़ी सी बातें कर दी हैं. आई होप यू डोंट माइंड.
ओके,
तो नईम साहब अब आप कुछ कह लें.
पहले मुझे तो उतारने दे.
आप बता लें फिर करें.
हाँ मैं फिनिश कर दूं. हाँ जी, इंक्यूबेटर के लिए यू हैव टू डिस्मेंटल इंक्यूबेटर, all the parts. In our hospital there is a spray shower is there for washing this one, but if you don't have Savlon water mop, you can be used. Remove this one, all items which is removable, remove this one, wash or clean it, soap and water or Savlon on this one, water, then clean with soft towel or the paper towel, and finally disinfect with this Clorox and water. Mop or spray, let it air dry, and after air dry you have to clean this one with the paper towel because the residue will be there. Powder, wherever it is there, you have to remove. Either during use you have to daily you have to top up this बस 2 मिनट ये बता wash with the soap and water and disinfect with the Clorox and use sterile water. Okay. Please, if you नहीं करनी तो let it one time disinfect and leave it there and fine. ना 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 नहीं बस तो उसको क्लोरेक्स से वाइप कर दें, ये स्प्रे मार दें. अच्छा, now I will tell how to remove PP. This is very important because during COVID this produced lot of problems for the doctors and healthcare workers. ये निकाल के वॉशेबल होंगे ना इतना. हाँ ये तो वॉश, ये हाँ ये सब तो वॉश में तो सारी चीजें आई. हाँ विजिबल उसको सोप एंड सेवलॉन एंड वाटर से वॉश करके क्लीन करके उसको जो भी डर्ट्स है वो क्लीन करेंगे, तो उसके बाद ही करेंगे ना जी.
पहले आप उसकी वो विजिबल चीजें
विजिबल
फिर आप क्लीन करके फिर क्लोरेक्स का स्प्रे
लास्ट क्लोरेक्स डिसइंफेक्ट करके.
हमारा इशू में हमारे पास भी यही इशू है.
नहीं वो डिसइंफेक्ट.
This is a very big issue, cleaning of the incubators. The nurses should know how to clean it.
Filter when dirty it is तो cleanable होता है छोटा. नो नहीं 30 नहीं, एक सिंपल फिल्टर भी तो होता है इसमें.
हाँ, but this should be done by the CSSD for you. हाँ तो वही कह रहा हूँ, you have to have a department.
कौन सा फिल्टर?
CSSD, you have to have a department of infection control.
Fully agree that it has to be the responsibility
Yes.
of it, but if they don't do it,
no नहीं इसका
Of course.
आप बस ये वो इसको ये तो वॉश हो सकता है, ये एयर ड्राई हो जाएगा ना. क्लीन कर दें या इसको तो क्लीन तो करो ना, इसको क्लीन करके स्प्रे मार दें कोई हो जाए कुछ तो. अच्छा जी, हाउ टू रिमूव पीपी. फर्स्ट ऑफ ऑल आई हैव टू रिमूव गॉन. I will not touch from here. I will go back of my back. I will break this ties from behind. Remove. Okay. So first, I remove the gloves. Then I have to disinfect my hand with the hand hygiene. Now I will break from behind. I will put my hand from behind and break this one from here. And put my hand inside. I will drag it straight, go inside and remove this one from, you can catch it from here. From here, inside you can touch it. Remove it, fold it small from inside out, make a ball and throw it. Okay, ji. Finally, mask. I will.
Yeah, there was a question about the distilled water used in the incubator.
What?
Distilled water.
Distilled
कहाँ से
water.
लें? What is it should be the source and what kind of distilled
Distilled
water?
water. I don't know. यहाँ available sterile water हो तो वहाँ भी नहीं इस्तेमाल होता हमारे यहाँ, मुश्किल है.
आपका ये क्वेश्चन था ना?
Pharmacy can produce the sterile water up in your hospital. आ जाए ना सब. नहीं, not the sterile water. Basically, sterile water. It is not available routinely. Sterile water. ना, हाँ बस वही.
हाँ, boiled water can be used. That's one simple thing.
ना नहीं. हाँ वो रिवर्स osmosis करके दे देते हैं आपको.
Thank you very much. This is the inline suction for the endotracheal tube. Dr. Sikandar gave it to me. Probably it's available in Lahore. So if you can afford, maybe it's better to use this one instead of using the other suction for the endotracheal tube. So it's available here. दूसरा सर आपने जो बात की थी about disseminating this message. So we're going to collect all this material, teaching material, and we'll put it in the academic neonatology group. So any one of those who are not the members of academic neonatology, please do join us. We'll share these videos and we'll also start a question answer session. Probably I'm going to include Dr. Hashmi in the group. So you can continue to ask your questions about how to manage your NICU from the infection control point of view. And I know most of the hospitals don't have the infection control and prevention departments, and they don't even have CSSD. So then you have to work out locally what to do, and you have to collaborate with your surgical theaters. Maybe they can help you. Yes, but again, the most important thing is the hand hygiene. And that is done by the infection control. They come every day. We don't even bother. They come, they monitor, and they supervise it, and they implement it. And NICU is one area in which we want 100% hand washing.
मैं एक गुजारिश करूंगा, आप मुझे बता सकते हैं कि इसमें डॉक्टर्स कितने और नर्सेज कितनी हैं? डॉक्टर्स हाथ खड़ा करें और नर्सेज, तो नर्सेज तो आटे में नमक के बराबर है, फिर भी है। अच्छा अच्छा, और किस अस्पताल मतलब है, कोई अस्पतालों का मुझे बता सकते हैं? आप चिल्ड्रन से हैं और आप हैं फौजी हैं, वो तो कैटेगरी और है, उसको है, वो तो स्पेशल कैटेगरी है। सलमान साहब यहाँ बैठे हुए हैं और डॉक्टर साहब इधर बैठे हुए हैं, मैं बहुत अदब से कह रहा हूँ कि वो तो कैटेगरी और है। अच्छा, ये बताएं कि ये देखिए ना, अब मैं ये गुजारिश ही थी सज्जाद साहब कि देखिए ना, अब ये चिल्ड्रन अस्पताल की नर्सेज हैं, यहाँ कितने अस्पताल हैं हमारे शहर में, और हमारे प्रोविंस में कितने शहर हैं? वो हाफिजाबाद से हैं भाई। कहाँ से हैं? हाफिजाबाद से। देखो मुझे याद है अब विच इज वेरी गुड। ये जब वहां जाएंगे ना, तो ये उन लोगों को ये आपने बातें समझानी है, बतानी है। जो हमारे वीडियोस हैं, ये चिल्ड्रन अस्पताल में देखने का कोई फायदा नहीं है, क्योंकि उनको प्रॉब्लम पहले ही पता है। जो आपकी ऑडियंस है वो यहाँ है ही नहीं, जिनको आप बताना चाह रहे हैं वो यहाँ मौजूद नहीं है, तो हमें उन लोगों तक पहुंचानी है ये बातें, वरना ये हम फिर अगले साल 2 साल के बाद यही बातें कर रहे होंगे और उसका कोई फायदा नहीं हुआ होगा। प्लीज मेरी बात का बुरा ना मानिएगा, ये बातें नईम नहीं करनी थी, मगर चूंकि नईम अभी कुछ सोच विचार में है तो मैंने कहा मैं पहले कर लूं, आखिर में ये कह देंगे। ये बहुत से लोगों को आपने खास तौर पे, वो मैं बता रहा हूँ कोने में हाफिजाबाद में ये वीडियो देखा जाना चाहिए, आर्मी में भी देखा जाना चाहिए, चिल्ड्रन में भी देखा जाना चाहिए। मगर लाहौर में कितने अस्पताल है? मेयो है, सर्विसेज है, गंगाराम है, फातिमा मेमोरियल है, गॉड नोज LGH है, कितनी तो गवर्नमेंट हॉस्पिटल्स में कह रहा हूँ। और फिर हर जगह छोटे छोटे अस्पताल है, हर एक के पास नर्सरी है, हर एक के पास सो कॉल्ड न्यूनेटल यूनिट है। कल मुझे हाफिजाबाद वाली बच्चियां बता रही थी कि उनके पास वहां पर वेंटिलेटर है। डॉक्टर साहबा मुल्तान में बैठी हैं, ये किसी अभी यूनिट ज्वाइन किया इन्होंने, वहां पर इनके पास ये सारा कुछ है। लोगों तक पहुंचनी चाहिए ये चीजें। कैसे पहुंचेंगी? आप बनाएंगे और सिर्फ अपने एकेडमिक उसमें नहीं डालेंगे, सिर्फ ये आप देंगे इनको, और ये सब में पूरे अस्पतालों की लिस्ट बना के फैलाएंगे, फिर कोई बात बनेगी। ठीक, आर्मी वालों को तो आप एक को भी देंगे ना, तो ये 1 मिनट में सलमान साहब को आप दें, इंशाल्लाह वो तमाम जो यूनिट्स हैं, इनका सिस्टम बहुत अच्छा है, ये अपने सारे यूनिट्स को ये पहुंचवा देंगे। तो इधर सिकंदर को, कहाँ है सिकंदर? वो जब से मैं ढूंढ रहा हूँ गायब है, तो वो उसको दें, तो वो सारे पंजाब के अस्पतालों में है।
अस्सलाम वालेकुम सर, मैं
सिकंदर आजम चला गया।
सिकंदर आजम इधर ही है सर। सर मैं कुछ कहना चाहती हूँ कि ये इन्फेक्शन कंट्रोल पे अगर हमने अच्छा काम करना है ना, तो हमें हर हॉस्पिटल से नर्सिस को लेना पड़ेगा, क्योंकि सबसे अच्छा जो इन्फेक्शन फ्री कर सकती है ना, वो नर्सिस कर सकती हैं। नॉलेज भी है, स्किल भी है, और उसको यूटिलाइज करने का सिर्फ मौका मिलना चाहिए। तो जब तक हम लोगों को शेयर नहीं करें, जैसे चिल्ड्रन वाले करते हैं, इस तरह बाकी हॉस्पिटल के लोगों ने नहीं किया, इसमें पार्टिसिपेशन नहीं करवाई, तो ये बड़ा अच्छा प्लेटफॉर्म था, हम लोगों को बता सकते थे। लेकिन बात वही है कि अब चिल्ड्रन ही हर जगह पे, या तो यहाँ के लोग भेजे जाने चाहिए जिससे हमें फायदा, और पूरा पंजाब जो है ना इस चीज से फायदा हासिल करे। थैंक यू।
एक बात ये कि स्टरलाइजेशन और ये सब चीजें जो यहाँ डिस्कस हुई, इट इज वेरी इंपॉर्टेंट। प्लीज रेज योर हैंड, हाउ मेनी ऑफ यू डूइंग द हैंड हाइजीन? ओके, एवरी डे, बिल्कुल, यानी कि रिलीजियसली, ठीक है। दैट्स द ओनली थिंग, बिकॉज आई एम टेलिंग यू कि हैंड हाइजीन जिसने शुरू की थी, सिर्फ hand hygiene से he reduced the infection rate in OBGYN, Semmelweis, the Hungarian obstetrician, by 35%. Only hand hygiene, no sterilization, nothing, only hand hygiene. So please continue to do that. And
yeah,
Sir,
thank
if
you
you
very much.
permit a
Just
small
for
comment.
a minute, yes, we agree with this. Please note that nurses are the backbone, and nurses are extremely important, and they are the ones who drive the whole service. So we have to go back and train our nurses as well as all the staff which works with them. Yes, name, sir. Name, kuch kehna tha? Anyone? Asad, yes.
Sir.
Ji bataye.
So a very small comment. I had a very small experience regarding ayas. Ayas are, if you look at it from the perspective of an ayah really doesn't have much growth in terms of how she's going to progress. For her, daily work is something that's a bother for her. So what I did was I took 2 ayahs and I taught them some basic stuff about cells, about bacteria. I was only able to take 2 lectures of the ayahs, but I got feedback from the nurses that they were feeling very included, very proud that they were actually taught something. So I think ayahs, if they are included in education activities, they might feel prouder and more motivated to actually do the work rather than they.
That's right. I think everybody should do that. And that's what we are saying. NICU is a teamwork. It is not one-man show. Please remember. Okay, it's a teamwork, and every single member of the team is equally important, whether that is the neonatologist or any IR, whatever.
Assalamualaikum. Can I make a comment? I think the gentleman who was you were speaking, that's the most important thing. There's a famous, this is a real thing happened at Mayo Clinic in Rochester. They were having a site visit by JACO, which is the organization that certifies the hospitals. And there was a janitor, Jamadar tha, safai kar raha tha wo. And the inspector asked him, so considering the lowest end of the totem pole, what do you do here? The janitor who was cleaning the floors, he said, what do you do here in this hospital? And look at the confidence of that gentleman. He said, I save lives. The pride he had in the work he did. And हमारी nurse बहन बोल रही थी, I think it's extremely important कि unless we are going to fix our paramedical services, Dr. साहब कह रहे थे कि infection control, I've been doing infection control for 35 years for 5 hospitals. We never go into the NICU and do any of that cleaning. I have 18 infection control nurses. We never do that. There's a group of people who are dedicated for doing that sort of work. The infection control nurses, their job is to train and educate them. So everybody has a role to play. I think, unfortunately, हमारे साथ एक Russian physician थी. She came from Russia. She was the #2 children's hospital in Moscow. She did not know even how to put an IV. And I asked her, okay, why don't you know that? She said, there are so many people there. This is 30 years ago. We have a dedicated team who just does IVs. In the United States, that's happened 10 years ago now. So everybody has a role to play. And unless we give each and every part of the team the pride and the work, you know, वो आपने सुना होगा famous story कहावत है कि एक दिन वो जा रहे थे, एक वहाँ अंधा नाबीना बैठा हुआ था, तो 3 लोग गुजरे. तो पहले वो एक थानेदार गुजरा, उसने उसे एड्रेस किया. अब वजीर गुजरा, फिर उसने उसको एड्रेस किया. फिर उसका बादशाह गुजरा, उसने एड्रेस किया. तो उसने बादशाह ने पूछा यहाँ से कौन कौन गुजरा था? उसने कहा पहले थानेदार गुजरा था, फिर वजीर गुजरा था, अब आप बादशाह सलामत आए हैं. तो उसने कहा आपको ये कैसे पता चला? उसने कहा आपकी अपनी वसात से आपने मुझे एड्रेस किया था, आपने मुझे सबसे ज्यादा इज्जत दी, तो आप बादशाह ही होंगे. Unfortunately, unless we get to that sort of a thing, we are not going to encourage the ayahs. We need to treat them as they are a part of our team. And not just the ayahs, everybody, because as the janitor said, he saves lives.
Thank you very much. I think we have overrun for 30 minutes and we are going to end the session here. Anything?
One comment.
Naeem, do you want to say anything quickly? Yeah. He is our guest of this session. Thank you very much.
Thank you.
Short comment.
Please.
Regarding the ayahs, there is a very small comment because ये जो ayahs के अलावा एक और category है helpers की. I did not know about this category because in military hospital NICU, what happened is we were the ayahs were really helping in the care of neonates and we were teaching them how to do the disinfection and others. तो कुछ अरसे के बाद एक आया डिसअपीयर होती थी, उसके बाद फिर एक आया डिसअपीयर किया, यार ये किधर जा रहे हैं जिनको हम ट्रेन कर रहे हैं. तो वो पता चला कि दे आर बीइंग एम्प्लॉयड एज हेल्पर्स इन सम NICUs. कहीं आज़ाद कश्मीर जा रही है कोई, बाद में वो मिल गई तो उन्होंने कहा जी नहीं हम तो वहाँ एज हेल्पर्स काम कर रही हैं, वी आर डूइंग द जॉब ऑफ द नर्सेज देयर. तो ये जो बड़े बड़े न्यूनेटल यूनिट्स हैं, यहाँ से जो आयाज हैं ये प्रमोट होके हेल्पर्स हो जाती हैं, उसके बाद प्रमोट होके नर्सेज का, न्यूनेटल नर्सेज का काम करती हैं. एंड आई थिंक ये कैटेगरी जो है ये हमें इग्नोर नहीं करनी चाहिए एंड इनको डिसइंफेक्शन में हमें शामिल करना चाहिए बिकॉज दे आर अल्टीमेटली वर्किंग एज नर्सेज. तो इसलिए आपकी जो कैटेगरी है ना आयाज, हेल्पर्स, नर्सेज तो बहुत हाई कैटेगरी है जिनको ये इन्हीं से ट्रेनिंग लेते हैं. थैंक यू.
थैंक यू वेरी मच.
जनाब बहुत बहुत शुक्रिया. मेरा ख्याल है मेरा काम मुश्किल और आसान बना दिया. आसान इसलिए कि बहुत सारी बातें जो मैंने करनी थी वो प्रोफेसर साजिद मकबूल साहब ने, फिर मुबीन ने और अभी जनरल सलमान साहब ने कर दी. मुश्किल इसलिए बना दिया कि मुझे बार बार कहा जा रहा है कि जी नेक्स्ट सेशन शुरू होने वाला है, लिहाजा आप अपनी बातें इंतहाई मिनिमम पे रखें. मैं पेजेस के नोट्स बनाए थे तो मेरा ख्याल में मैं उसमें से सिर्फ 2 बातें ही कर सकूंगा. आई डोंट वांट टू गो टू द डिटेल्स, आई डोंट वांट टू जो टाइम ज्यादा नहीं लेना चाहूंगा, लेकिन मुझे एक बात पता है, नियोनेटल मोर्टेलिटी जब हम स्टूडेंट थे आज से 40 साल पहले तब भी 40s में थी, यानी 47, 48. आज भी 40s में है. कल मुझे बड़ी खुशी हुई जब हमने सुना कि वो 39 पे आ गई है. नियोनेटल मोर्टेलिटी की बात करें. एनीवे, और इसको मैं रिलेट करूं अगर नर्सरी से, जिस वक्त मेरी बेटी जो कि अब 32 साल की है उसको नियोनेटल जॉन्डिस हो गया तो मुझे मेयो अस्पताल वालों ने, उसका 20 था जॉन्डिस, उन्होंने हाथ जोड़ के कहा इसको नर्सरी में मत रखना, ये बच के नहीं जाएगी. मुझे उस वक्त के याद है वो केसेस कि जब वो बच्चे, हम न्यूबॉर्न 900 ग्रामर और 1000 ग्रामर को बचाने की पूरी कोशिश करते थे. 1 हफ्ते के बाद एक दिन सुबह मैंने देखा एक आया आई, हंसते हंसते उसने इंक्यूबेटर साफ किया, लो एंड बिहोल्ड अगले दिन सेप्टिसीमिया हो गया. सो दीज वर द थिंग्स दैट वर हैपनिंग देयर एंड व्हाट इज हैपनिंग नाउ. मैं एक नर्सरी में गया, मैंने हाथ धोए. एक दिन मैंने उसको जो नहीं होता ये स्टेरिलियम से हाथ साफ किया और मैं उसको हवा में सुखा रहा हूं, वो जो 20 सेकंड वाला है. तो वहां के नर्सरी के डॉक्टर मुझे कहते क्या कर रहे हैं आप. मैंने कहा भाई 20 सेकंड का टाइम है. अच्छा हम तो स्टेडियम लगाते हैं और साथ ही काम शुरू कर देते हैं. सो इफ आवर हैंड हाइजीन, इफ आवर थिंग्स हैव नॉट इम्प्रूव्ड, इट इज रिफ्लेक्टेड इन आवर न्यूनेटल मोर्टेलिटी. द मोस्ट इंपॉर्टेंट थिंग सर, विद ड्यू रिस्पेक्ट, सिकंदर आपने बहुत अच्छी प्रेजेंटेशन दी थी. मैं जीरो टॉलरेंस की बात नहीं कर सकता. जीरो टॉलरेंस का मतलब है ये तमाम बातें. इन्होंने बहुत अच्छी बात की, अभी इन्होंने सज्जाद साहब ने, कि 35 to 40%, सर आपने शायद बात की थी, 35 to 40% हाथ धोने से हो गया. हमें एज चिल्ड्रन हॉस्पिटल, एज पीडियाट्रिक फ्रेटर्निटी वो मेथड्स ढूंढने हैं कि हम मोर्टेलिटी को, इन्फेक्शन कंट्रोल को 10-15% पे ले आए. 10-15% स्पेंड करके, 100 के लिए हमें 100 स्पेंड करना पड़ेगा. हम 10-15 स्पेंड करके 90 बचा सकते हैं थ्रू वेरी सिंपल मेजर्स. और वो आपको पता है कौन सिखा रहा है? कल यहाँ पे किड आर्ट कंपटीशन लगा हुआ था, तमाम बच्चों ने हाथ धोने, सफाई के तरीके बताए हुए थे. आज के बच्चे को ये बातें पता है, हमें क्यों नहीं पता? ऑल वी नीड इज, जिस तरह सज्जाद ने बात की है, आपकी टीम्स होनी चाहिए, मेथडोलॉजी होनी चाहिए, मोस्ट इंपॉर्टेंट चीज है जो हम कभी नहीं करते। जिस तरह साहिब साहब कह रहे थे ना कि हमारा कंसल्टेंट आता है और बातें करके चला जाता है और वो हाथ और मोबाइल सुनता है, हम लोगों ने मेथड्स को रखा नहीं है। हमारे ख्याल में जितना बड़ा डॉक्टर होगा वो उतनी छोटी बातें नहीं कर सकता। नहीं भाई, आपको टीम्स वर्क में बहुत जरूरी है कि ये माइनर वर्क करना है। नर्सेज हमारी इंतहाई इंपॉर्टेंट शोबा है। आया, बैरे और जो स्वीपर है बड़े इंपॉर्टेंट शोबे। इट हैज टू गो टू एवरीबॉडी। एंड द फाइनल वर्ड अगेन गोइंग बैक टू प्रोफेसर सज्जद साहब, जो वीडियोस बना के बात कर रहे हैं, मैं पीडियाट्रिक एसोसिएशन की तरफ से आपको यकीन दिलाता हूं, आप वीडियोस बनाइए, फ्लायर्स बनाइए, ये लीफलेट्स दीजिए। हम हर अस्पताल में, हर पेरिफेरल यूनिट में, इवन अगर आरएचसी में पीडियाट्रिशियन बैठा है, वहां पहुंचाने की जिम्मेदारी मेरे जिम्मे डालिए। आप बनाइए चीज। थैंक यू वेरी मच।
Thank you very much. I think we end this session over here.
Yes, sir. In the
As
end, I would
Professor
like.
Manzon is online. Thank you very much, Dr. Hashmi and everybody, and big clap for all those who participated.